Hello, everyone. I'm Allie, and I'll be presenting on the epidemiological aspects of chronic obstructive pulmonary disease, otherwise referred to as COPD. As an introduction to what COPD is a chronic respiratory disease that restricts airflow of the lungs and consequently influences the quality of breathing. There are various types of COPD that are characterized either by inflammation, excess mucus production, and/or damage to the alveoli, but I'll get to that later in my presentation. COPD is also a progressive disease, which means it only worsens over time without continuous and progressive treatment. COPD is also now the third leading cause of death worldwide and is the sixth leading cause of death in the United States. Some of the defining characteristics of COPD include a reduced forced expiratory volume, a reduced forced expiratory volume to forced vital capacity ratio, and an increased residual volume. It can also be characterized by inflammation, mucus hypersecretion, and/or parenchyma. The primary cause of COPD is smoking, whether it's cigarette or tobacco smoke. And it can also be caused by indirect contact with smoke, such as secondhand exposure, and less commonly, occupational exposures to chemicals and noxious particles, as well as a genetic deficiency in alpha-1 antitrypsin, can also play a role in the causes of COPD. Some of the symptoms of COPD include, but aren't limited to, a chronic cough with sputum dyspnea, wheezing, and chest tightness. Now, the main derivatives of COPD are emphysema, which is characterized by alveolar damage caused from cigarette smoke, and chronic bronchitis, which is inflammation of the bronchi that can exhibit mucus production. In emphysema, because the alveolar tissues are damaged, they lose their elasticity. And then in chronic bronchitis, the inflammation causes the constriction of the airways, which inhibits respiratory function and quality of breathing. Other derivatives of COPD also include asthma and cystic fibrosis. Without treatment for these conditions, airway remodeling, thickening of the airway walls, and fibrosis may occur. Now, moving on to the epidemiological aspects of COPD. COPD risk factors include smoking, burning of wood, and industrial toxic gases, age, existing comorbidities, and I already talked about, or I already discussed smoking pollution as a risk factor, but to touch on age, older individuals are at greater risk for COPD because most lung damage takes place over a longer period of time. And one additional risk factor is comorbidities because they can significantly impact the mortality of those with COPD. Using the table of the daily versus time, we can conclude that the overall burden of disease is highest for individuals who are 50 to 69 years old. Comparatively, we can see that younger individuals are at lower risk for COPD. And then the time range ranged from 1995 to 2015. In 2019, the highest age standardized death rates occurred in Nepal, Papua New Guinea, and the Solomon Islands. The bar graphs show the prevalence of COPD per 100,000 people in each country. 4/5 of the COPD cases occur in low to middle income countries, and then the smoking rates in rural areas are 2 times the rate as compared to cities, which can explain why COPD prevalence is very high in these areas. COPD, as it relates to gender, is increasing in females, and they have a higher mortality rate than men. The COPD symptoms are also much more severe than men because women have smaller airways. So the same amount of exposure to smoke can impair women much more efficiently than men. And then one reason we can use to explain this is that a rise in COPD amongst women is because more females are being exposed to pollutants and smoke from jobs. Using both of the graphs, we can see a decline in male COPD mortality rate with an increase followed by a constant trend for female mortality rate. We can also see that 6.1% of females have COPD versus the 4.1% of males with COPD. COPD is most commonly found in the stroke belt of the United States. And these places, for example, can include West Virginia, Kentucky, and Arkansas. And globally, COPD is most prevalent in Northern and Southern Asia, Eastern and Southern Africa, Southeast and Southwest Canada bordering the US, and most of Europe. All of these places are indicative of having high rates of COPD prevalence. Amongst the various income countries, so the low middle, upper middle, and the high income countries, we can see that low middle income countries have the greatest burden for COPD, and influential factors could include, but aren't limited to, the smoking rates in these areas, the prevalence of pollution, the lack of education, and the limited access to healthcare. Comorbidities are also very important to consider in the diagnostic and personalized treatment plans for patients with COPD. The most notable comorbidities of COPD are hypertension, osteoporosis, cardiovascular disease, and lung cancer. And it's necessary to consider these comorbidities for diagnostic techniques because these comorbidities pose a challenge in the assessment and the effective management of COPD. And then these comorbidities give rise for patient-specific treatments. Additionally, comorbidities also emphasize the need for proper education amongst patients and healthcare workers, so patients may effectively manage their condition. There are various types of diagnostic techniques available for COPD. One is the spirometry lung function test, which primarily looks for low forced expiratory volume, which can suggest obstruction. There's the screening for blood tests that can detect the presence or the lack of the alpha-1 antitrypsin deficiency. There's the oximetry or the arterial blood gas test that can test for the oxygen level in the blood, which can show how well the lungs are moving oxygen in the blood and removing carbon dioxide from the blood. And then the last one I want to mention is the CT scan that can identify different types of COPD, such as emphysema and chronic bronchitis severity. There are multiple organizations working towards COPD, but the most pertinent organizations that are heavily influencing COPD progress today are WHO, ALA, and GOLD. The WHO is implementing policies to rid of smoking and tobacco usage. The GOLD is working towards providing evidence-based guidelines for healthcare professionals and policymakers to enhance COPD treatment. And lastly, ALA is the leading organization fighting against lung diseases. All of these organizations are dedicating themselves to improving the lives of those with COPD. Thank you, and that concludes my presentation.